it's an ongoing debate whether there is still merit for treatment with chemoimmunotherapy. Now that we know that you have markers that define or that predict for poor outcome on different therapies. And although in the US, it seems to be the case that most patients, virtually maybe all patients, will not get chemotherapy anymore at first-line treatment, in Europe, this is still under debate. The reason for that is that most of the studies of the recent years have shown that there is a lot of gain in progression-free survival, and overall survival is still a bit more difficult to say, but for sure, progression-free survival, novel targeted agents compared to chemotherapy. And the difference between progression-free survival is much smaller when you compare chemotherapy to novel agent for IgHV mutated patients. And since you have only so many cycles of treatment you can give to a patient and so many options, which is still limited, there is still something to say to treat patients with a mutated IgHV first with chemotherapy, so you have all other options still in your pockets. And there are even also people, also in the Netherlands here, that say, well, as long as you don't have a very clear overall survival advantage, there is still a good reason to not abandon chemotherapy completely for all groups, because you may be throwing away a very active treatment line. So it's a debate, and I think more and more it's something that you have to discuss with your patients in a patient-doctor relation, where more and more you can be, and it's a nice part of being a hematologist treating many CLL patients, is it's really you are guiding your patients kind of through the menu of options, and together you have to choose what are the trade-offs of the different choices you made. So I think there is a reason to look for high-risk features, for sure. P53, DL70P, we discussed already, IgVH maybe also, but it is something that is still on the debate and you should discuss with your patients. Notch mutation is a bit different ballgame. What has been shown by different groups, mostly the German group, is that patients with a Notch mutation are poor responders to antibody treatment, specifically rituximab. And that's why you can argue whether or not the patients with a Notch mutation should be treated with an antibody at all. Also, the real evidence of prospective trials is pretty limited.